Hello, and welcome to Digest This, where we discuss clinical topic in gastroenterology. My name is Francesca Moroni. I'm one of the gastroenterology consultants from the north of Scotland. Today we are discussing celiac disease, an update. And I'm delighted to welcome Dr. Alan Shand, a consultant gastroenterologist from a Western General in Edinburgh. Welcome, Dr. Shand.
Thank you, Fran. Thanks for the invitation.
Well, I often like to think about celiac disease as the Cinderella condition of gastroenterology. Virtually everybody knows enough about it, but not many people want to know more about it, which I found quite a shame because it's an excellent model for immunological-driven diseases. So what exactly is celiac disease?
I think calling it a Cinderella subject's a very good description. It's one of these subjects that doesn't seem to excite people's interest in the same way that liver disease or endoscopy or inflammatory bowel disease seems to do, and it's a great shame. We know what the trigger is for celiac disease. We know that the pathophysiology of the disease is fairly well thought through. It's something that I normally say to patients, it's a bit like an allergy, but it's not really an allergy at all. When you think about it, your intestinal immune system has a big job to do. All day long, it's trying to keep you well and keep you nourished. It's trying to recognise all this foreign antigenic material that we ingest, that we eat and drink every day. Trying to pick out things that are actually good for us, the food that we eat, and allowing those sorts of things a safe passage through for digestion and absorption. But at the same time, looking out for pathogens, looking out for things that might do us harm, and targeting those things for destruction, for immune-mediated destruction. And the trouble with people, or the problem for people with celiac disease, is that their immune system just can't get that balance right. And they recognise the good antigens in gluten-containing foods, so things made out of wheat, barley and rye, and they target those things inappropriately. We think that it probably all starts off with some interruption or problem with the intestinal epithelium and a degree of increased intestinal permeability. And what that does is allows more ingress of gluten-containing peptides into the lamina propria, and more contact with the mucosal immune system contained therein. One of the first things that happens is that tissue transglutaminase, which is found just below the epithelium, deamidates that gluten and makes it more attractive to HLA DQ2 or DQ8 binding sites, which you find on antigen-presenting cells. And probably the primary event is that cytotoxic gluten-specific T cells are activated through binding of their T cell receptors to that gluten DQ2 complex on the dendritic cells or antigen-presenting cells. And there's an outflow of interferon gamma and tumour necrosis factor, which causes a huge amount of inflammation in the lamina propria. And one other thing is that you get proliferation of B cells, which in turn produce much more tissue transglutaminase. So this horrible vicious cycle of inflammation is set up. More tissue damage, more permeability, more ingress of gluten, more inflammation, and so on and so forth. And the outcome eventually is what we would call celiac disease.
So what is the actual clinical outcome once we have perpetrated this inflammation and tissue damage?
Well, that's a very interesting question, because, of course, there is this tremendous heterogeneity amongst people with celiac disease. Celiac disease is a very common condition. Perhaps as many as 1 in 100 of us actually have the condition. But most of those people will probably live their lives without knowing that they have it, because many people, probably the majority of people with celiac disease, won't have any symptoms at all. Many people won't have any health problems at all. But some may manifest with the kind of classical symptoms that I was taught about, and I'm sure you were taught about, things like diarrhea, steatorrhea, weight loss, failure to thrive in children, abdominal pains, vomiting, that sort of classic malabsorptive picture. But those people probably only account for a tiny fraction of the total. We know from epidemiological work that's been done in the UK, particularly in the southeast of England, that probably for every one person with that sort of presentation, there are 7 other people out there who have a positive TTG, but either no symptoms at all or an atypical set of symptoms. Quite a number of people now who are picked up are either asymptomatic and they're picked up through screening, or because someone has done a blood test for celiac disease as part of a check for other things. Or they have much more vague symptoms. They might be tired all the time. They might have aches and pains in their joints, aches and pains in their muscles. They might just have a bit of weight loss. They might have very little in the way of symptoms. What we're seeing now are people who tend to be a little bit older when they're diagnosed, probably in their 40s or 50s or even beyond. They certainly haven't got the typical malabsorptive symptoms. And that in itself creates some issues because when they start on their treatment, when they start on their gluten-free diet, you might find that they actually gain weight. And that weight gain, which is actually a bit of a therapeutic goal when you've got the other group, becomes a bit of a disadvantage to this group. So there is a huge spectrum of disease, and one of the other interesting things is that the degree of intestinal damage doesn't necessarily correlate with the clinical presentation.
Very interesting indeed. And of course, you mentioned it's so prevalent in the general population. A lot of patients may be asymptomatic. So how do we diagnose it, and how we make sure that we pick all the patients with celiac disease?
So it may not be necessary to pick up everyone with celiac disease, which might sound a bit heretical, but I think the diagnosis is most secure when you have someone who comes along with symptoms, whether they're typical or atypical symptoms. They have the appropriate blood test, which is usually an anti-TTG IgA antibody, and that is elevated. They go on to have an endoscopy at which the requisite number of duodenal biopsies are taken. We aim to take 4 biopsies from the second part of the duodenum and another 2 biopsies from the first part of the duodenum. And those biopsies show a full house of histological abnormalities. So there's an increase in intraepithelial lymphocytes. There's a lot of lamina propria inflammation. There's villus atrophy to some degree, which might be quite mild, or it might be total or subtotal. And you get this corresponding deepening of the crypts. So crypt hyperplasia and villus atrophy. And if you have all of those things, then you're home and dry. That's a very secure diagnosis. The longer you go without gluten, the lower your anti-TTG drops, and the fewer histological abnormalities you're going to see. Now, it might take 2 or 3 years, even longer for some people, for the histological abnormalities to disappear completely. So the paediatricians for many years now have said if you have someone with symptoms who has an anti-TTG that is more than 10 times the upper limit of normal, and you do a confirmatory blood test, which tends to be an anti-endomysium antibody, which is a kind of predecessor test to the anti-TTG, and you also check for one or both of the HLA types that I mentioned earlier, HLA-DQ2 or DQ8. If you fulfill all of those criteria, then actually there is no need for that individual to undergo endoscopy. The reason being that there is a very, very small chance of it not being celiac disease. So they've been doing this for a long time, and it seems to be a safe and effective strategy. So why not in adults? And that is the million-dollar question. The last set of BSG guidance on celiac disease came out in about 2014 and came out in favour of histology. And that's been backed up by American guidance and European guidance published only last year, which still insists on histological confirmation of the disease. And then along came COVID, which upset everything, upsetting the endoscopy waiting times, making people wait even longer on their gluten-containing diet for a diagnosis. So this prompted a lot of soul-searching amongst people with an interest in celiac disease, and a change to the BSG guidance, at least an interim change, which said, very like the paediatricians, if you have someone who has symptoms, who has a TTG which is more than 10 times the upper limit of normal, then the next thing that you should do is a confirmatory blood test. Now, that could be an anti-endomysium blood test, an anti-endomysium antibody. It could just as well be a second anti-TTG. And if that is also greater than 10 times the upper limit of normal, and if your person is under the age of 55, then you can treat that person as celiac.
You mentioned that to have an accurate diagnosis, patients have to be on gluten-containing diet, but often they come to our clinic when they've already cut out gluten from diet. So how do we ensure in these patients we get the correct diagnosis?
So as things stand at the moment, this is a very difficult situation. Someone has decided to take gluten out of their diet, either because they've realised that that's what's making them ill, or they've been advised to do that, and they start to feel better. And they come along to the clinic and we say, well, if we're going to diagnose this condition, you're going to have to go back on gluten, or at least an amount of gluten, a specified amount of gluten, until we get round to endoscoping you. And we euphemistically call this a gluten challenge, and arbitrarily that's set at about 4 slices of normal bread, or the equivalent, each day for 4 to 6 weeks. And it is quite a challenge for people who have been ill for a while and are now starting to feel better again, and they get to hospital and we say, well, actually, you've got to make yourself ill again. However, there is hope on the horizon, and a lot of work has been done on looking at those gluten-specific T cells that I mentioned at the outset. We know from work done in Norway that those gluten-specific T cells persist in the lamina propria and sometimes in the epithelium of people with celiac disease. And that's a unique feature in people with celiac disease. The challenge is to try and turn that into a blood test. Can you find these gluten-specific T cells in peripheral blood? And with newer technologies, using tetramer technology to try and amplify the number of peripheral blood cells, or the number of cytotoxic T cells in peripheral blood, it is possible now to identify these cells. And these tests are still undergoing evaluation, but they are showing quite a bit of promise, and they are totally independent of the ingestion of gluten at the time of testing.
That's fascinating. I mean, I think the beauty of celiac disease is really in its treatment. It is the quintessential GI condition. It's caused by food and is treated by diet. It seems all so simple, but we know that's not always the case. So how do we ensure that we are successful in treating our patients with celiac disease?
So I smile because we often say to people, it's just a diet. And a lot of people are very happy that they don't need to take medicine, they don't need to take drugs. But it's not just a diet. It's a big change to people's lives. We're asking people to make a change whereby they take out all the familiar staple foods that they've been accustomed to throughout their lives. And we're asking them to do that for the rest of their days. So how do we try to ensure that they do it well and it's easy for them? And I think it's the latter thing there that's most important. We have to make it easy for people. We have to make the foods readily available. They have to be good quality, so they have to be fairly similar to the foods that everyone else eats. Gluten, or the lack of gluten, really affects the textures of foods. And how they handle when you're preparing them or cooking them or indeed eating them. So for example, gluten-free bread, your bread or your bun becomes more like a cake, but not in a good way. Things tend to crumble very easily, they're very dry. And all of these things are quite disappointing, and they demotivate people. People need motivation. So how do you motivate them? Well, on a day-to-day basis, what you hope is that people will start to feel better. So the big motivation is that I stick to this diet and actually all my symptoms go away. The availability of gluten-free foods makes things quite tricky, and often people fall down when they leave the house. So they're very gluten-free when they're in the house and they can control everything. But when they have to go to work, and there may not be a canteen that deals with gluten-free foods, there may not be a shop nearby that sells gluten-free foods. They may not feel able to get up early enough in the morning to prepare things and take them with them. And a lot of the gluten-free foods historically didn't really lend themselves very well to packing them in your bag and taking them to work with you. And there are still people who will fall through the cracks, perhaps people who don't have that additional money to pay for gluten-free foods. Now, we're very lucky in Scotland that we have a safety net there. We have the gluten-free food provision scheme, which I think is a very good scheme, and it allows that group of people to have a kind of staple, basic amount of the treatment that they need, just as they would get if they had diabetes or thyroid disease.
Well, certainly it seems that education for the patient is very important in this circumstance, and we probably have to thank our dietitians for the hard work they do in that.
Absolutely. From the very start, people need to see the right people, they need to get the right messages, they need to get consistent messages. In Lothian, we have piloted, well, as part of a Scottish Government pilot scheme, a way of trying to improve our care for people with celiac disease with a largely dietetic-led management plan for people with celiac disease. So the dietitians see people first of all, and are often the only people who will see them. They have a script that they follow, so they all say the same thing. It doesn't matter which dietitian you see, you'll be told the same thing. We try to make it easy for people, so particularly with the COVID restrictions, it's been very difficult for people to come up to hospital. The other thing that we've been looking at is a sort of talking head of a dietitian delivering their script, so that people can have that to watch at home or on their phone or their tablet. And perhaps most importantly, they can go back and look at the bits that they didn't quite catch the first time. They have that as a resource to go back and look at. So giving a consistent message, but most importantly, backing that message up with some form of multimedia, either written information, but probably more successfully a kind of audio-visual video type consultation seems to be a very good way of doing things. And the Scottish model for initial management and follow-up for celiac disease, what is proposed is that people will be managed initially by dietitians, followed up for the first year or two. The first year or two tends to be the most difficult time for people. It's when they struggle most to get used to things. And then after that, they're passed on to the community pharmacy team, who by dint of the gluten-free food scheme deliver an annual celiac checkup thereafter.
That's nicely leads me to the next question about follow-up. As you mentioned, these people should be follow up once a year, but what exactly are we looking for?
So follow-up is very important. Follow-up seems to be the only thing that's been shown to improve compliance with a gluten-free diet. But how that should look and what the elements of follow-up should be have always been somewhat controversial. So I think it's very important that whoever does the following up has an interest in celiac disease. So in many ways it doesn't matter if that's a gastroenterologist or a GP, so if it's a medical person, if it's a nurse, if it's a dietitian or if it's a pharmacist, but they have to have an interest. And I would argue quite strongly that the people best placed to deliver follow-up are dietitians, at least in the early stages. So the elements of follow-up at the moment are a questionnaire which asks about general well-being, some abdominal symptoms, it asks about height and weight and any changes, and any sort of alarm symptoms. Other tests over and above that are difficult. It's difficult to say just exactly what the utility of these things are. We've done a lot of these things in the past because we believe that they're helpful. So, for example, doing blood tests on an annual basis, the evidence that improves compliance in any way or improves the outcomes in any way is actually fairly equivocal and probably is lacking. But I would say that patients derive an enormous amount of comfort, much more than we might imagine as doctors, from having that set of blood tests. But the evidence that they are helpful is lacking. Some people advocate doing regular repeat biopsies, so going through the endoscopy that we've already said might not be necessary for diagnosis, and using that as a follow-up. There are new tests also. I say new, they've been around for a few years, but new technology which looks at the evidence for gluten ingestion over the last few weeks. So there are urine tests and fecal tests which look for gluten peptides in urine or feces. And these are looking to be very useful tests for assessing people's compliance with the diet.
What about DEXA scan? Should we do them? Should we calculate people's risks of osteoporosis?
So, as you're absolutely right, osteoporosis is a risk in celiac disease. So those people who are malabsorbing are certainly at increased risk of osteoporosis, but not everyone is at the same risk. So scoring systems such as FRAX or QFRAX, they've both been validated for use in celiac disease. Different areas of Scotland use different questionnaires, but people should be scored at diagnosis or at least a year after being on a gluten-free diet. And if they score high on one of these scores, then yes, they ought to have a DEXA scan. Other people don't need to have that.
So we all had that patient that we believe been on a gluten-free diet sustained for a period of time, but they're still symptomatic. So how should we manage them, and what should we be worried about?
So many people will come back struggling on a gluten-free diet, and the majority of those people, perhaps up to 50% of them, will be struggling because they haven't quite been able to become totally gluten-free for one reason or another. So one of the first things we should do is send those people back to speak to the dietitian. And it's a real case of detective work for the dietitian. It's trying to figure out, is there gluten getting in there, and if so, where? How can we help here? So some of the best questions to ask are: have you joined Coeliac UK, the patient support organisation? And certainly in the past, we used to find that people who hadn't engaged with Coeliac UK were less likely to be doing well. But that was in the era prior to walking into the supermarket and being confronted with a shelf full of gluten-free foods. Other very important questions to ask are: do you eat out, and if so, how often? And then to ask things about shared food preparation areas, shared work surfaces, shared toasters. Even the cleanest toaster in the West End of Glasgow will be harbouring some crumbs, and toasters are a notorious source of cross-contamination. So these are all the kinds of things that the dietitian will ask. If the dietitians are very happy that they can't find any sign of gluten exposure, then we need to take a full history. We need to find out what the symptoms are. We need to examine the patient. If there's a concern that they're not responding, truly not responding, then the next step would be to repeat their duodenal biopsies, assuming that they had a duodenal biopsy in the first place. And what we're looking for there is evidence of persisting villus atrophy. But we're also looking to see if there is any evidence of abnormal T-cell populations within the duodenum, and particularly to see if there are clonal T-cell populations, which might suggest the more severe, the more worrisome form of refractory celiac disease, or that these people are on a spectrum that is leading them towards lymphomatous transformation. But it may be that all of these things come back as normal, in which case you have to keep an open mind. You have to wonder, well, is there some other associated condition or even an unassociated condition? So, for example, have they got inflammatory bowel disease? Is this somebody who happened to have a positive TTG, but they've actually got Crohn's disease or ulcerative colitis as well? And again, depending on symptoms, you might want to focus your investigations on the small bowel or the large bowel or both. You might wonder about microscopic colitis. We know that microscopic colitis is probably 3 or 4 times more likely in people with celiac disease than it is in the general population. So it may be necessary to do a colonoscopy just simply to look for that. You might think about small intestinal bacterial overgrowth, a very trendy diagnosis, but it is more common in people with celiac disease and can masquerade as ongoing symptoms. And you might have to think about other things like pancreatic atrophy or pancreatic exocrine insufficiency, both very rare but well recognised sequelae of celiac disease, which again can cause ongoing symptoms. These things won't respond to a gluten-free diet. And then we move on to the non-associated things. We move on to coexisting diagnoses. In the older population, you might start to think about cancer, think about malignancy. And again, those might be celiac-related malignancies like small bowel adenocarcinoma or non-Hodgkin's lymphoma or the very specific enteropathy-associated T-cell lymphoma, which is probably the least common of all the lymphomas that we see in people with celiac disease. That's
very interesting indeed, actually. Do you have any take-home messages for us before we conclude this interview?
So I think the first thing is that celiac disease is out there. It's common. It's probably more common than a lot of the other GI diagnoses that we look out for. So think about it. The best way to diagnose it is to think about it. Don't be put off by the age of the patient. It's not a disease of young people exclusively. It affects all ages. 20% of people diagnosed will be over the age of 60. Don't be put off by the nature of the symptoms. If you think someone might have it, then do the right test. And the right test is an anti-TTG antibody. That's an IgA antibody. So if you have somebody who might have coexisting IgA deficiency, again, something that's a little more common in people with celiac disease, and the IgA antibody comes back negative, do make sure that you know the level of total IgA. And if there's a suspicion of IgA deficiency, then you can ask for an IgG antibody. And some laboratories will do that for you automatically. If we find a very, very low level of anti-TTG IgA, some laboratories will automatically run an anti-TTG IgG antibody for you. But think about it. It's out there. And perhaps the other message is, if you do find someone has it, do encourage them to stick with gluten until we have a definite diagnosis. But watch this space, because I think that the world is about to change again when these gluten-specific T cells and the tests that stem from those, when they hit the market, I think we're going to see big changes.
Well, all is left for me to say is to thank you for an excellent run through this very relevant topic.
Thank you very much.
And to thank you for joining us for Digest This.